All right, let's jump right into this explainer. We're tackling a heavy one today, but honestly, it is absolutely crucial. How we assess and prevent suicide risk in healthcare. This isn't just some academic exercise, right? It's literally a matter of life and death. And frankly, the way a lot of us have traditionally thought about it is fundamentally flawed. So, we're going to dig into the data, the clinical guidelines, and most importantly, the profound human elements of keeping people safe. So we're kicking things off with a massive paradigm shift. A lot of us think a suicide assessment is about predicting the future. It's not. Predicting human behavior with absolute certainty is impossible. Instead, the goal is to act as empathetic listeners. We want to truly understand the root of the pain. It's about getting a grasp on the unique distress of the human being sitting right in front of us, which then allows for a much more informed, meaningful intervention. Which naturally brings up a pretty big question. If trying to predict suicide isn't the actual goal here, how on earth do we establish safety? How do we foster hope and build a bridge over that moment of total despair? Well, here is our roadmap to figure that out today. We'll cover 1. The scope of the crisis. 2. Unpacking suicide versus self-injury. 3. Identifying risks and warnings. 4. The power of connection. 5. Protecting vulnerable populations. And finally, 6. Meaningful interventions and safety. Let's start with Section 1, the scope of the crisis. First things first, we've got to talk about the words we use, because language strips away stigma. The way we talk about this completely shapes how we treat it. That's exactly why clinical guidelines insist on respectful phrasing, like died by suicide. Think about it. The word committed implies a crime or a sin, right? And calling it successful is just a terrible, terrible way to describe a tragic loss of life. Adjusting our vocabulary is literally step 1 in creating a safe space for someone to ask for help. Just to wrap our heads around the sheer scale of what we're dealing with, let's look at the data from Statistics Canada. In 2016 alone, 4,000 deaths by suicide were recorded. And honestly, that is just the tip of the iceberg. The sources show that for every single death, there are 5 hospitalizations for self-inflicted injuries. The ripple effect that has on families, friends, and entire communities, it's staggering. But those national averages, they actually hide a deeply painful reality. When you look at Indigenous communities in Canada, the rates are starkly disproportionate. We're talking about Inuit populations experiencing a suicide rate 9 times higher than non-Indigenous populations. First Nations are 3 times higher. It's incredibly important to realize these aren't just random statistics. They are directly tied to historical trauma, forced relocations, residential schools, and this massive loss of cultural continuity. Moving on to Section 2, unpacking suicide versus self-injury. Okay, we need to clear up a very common misconception. People often use self-harm and suicide interchangeably, but medically speaking, they are totally different. Suicidal behavior is defined by a clear intent to die. On the flip side, non-suicidal self-injury, or NSSI, which includes things like cutting or burning, involves inflicting shallow, painful injuries, but with absolutely zero intent to end one's life. So you might be wondering, why do it at all? Well, NSSI is primarily a coping mechanism. It's often a desperate attempt to alleviate overwhelming psychic pain or to self-punish. Sometimes it's used to pierce through this state of emotional numbness, what's often called anti-dissociation. When we understand that this behavior is actually an attempt to gain control over intense emotions, we can approach the person with real empathy instead of judgment or panic. Which brings us to Section 3, identifying risks and warnings. So how does risk actually build up? We basically divide the indicators into 2 buckets. First, you've got potentiating risk factors. These set the long-term stage. Think chronic pain, a history of trauma, or social isolation. That's your background context. But the warning signs? Those are the acute, blazing red flags signaling immediate danger in the minutes and days ahead. That's when someone is actively looking for lethal means, expressing a specific plan, or showing this sudden, intense hopelessness. To help clinicians actually remember these immediate warning signs on the fly, there's a really handy memory hook: IS Path Warm. If you see a sudden spike in substance use, intense anxiety, someone saying they feel totally trapped, or wild mood changes combined with suicidal ideation, the risk is escalating fast. At that point, you're not looking at long-term context anymore. You are looking at an immediate crisis. But hey, assessing risk isn't just about tallying up all the bad stuff. We have to actively hunt for protective factors too. These are the internal coping skills and external community supports that build a person's resilience. Things like a strong connection to family, a deep sense of belonging, or spiritual beliefs can actively buffer against suicide risk. Finding those strengths gives us the actual building blocks for a solid safety plan. All right, section 4, the power of connection. This brings us to what might literally be the most important part of this whole explainer. Your most powerful tool isn't a clipboard or a risk assessment checklist. It's the therapeutic relationship. The data, the guidelines, they are crystal clear on this. Everything rests on a foundation of active listening, trust, and real human connection. If your assessment feels like a sterile police interrogation, it's going to fail. A person in crisis absolutely has to feel seen, heard, and valued before they will ever open up about their true intent. Building that kind of life-saving rapport starts the literal second you meet. It's as simple as asking how they prefer to be addressed. It means listening with genuine empathy in a quiet, comfortable space, normalizing their pain, letting them know, hey, it is okay to talk about these dark thoughts, and just treating them like a human being drastically cuts down on their isolation. Let's look at section 5, protecting vulnerable populations. Taking that empathy a step further, we have to recognize that different demographic groups have totally different needs. Like with youth, you have to watch out for the contagion effect, where exposure to suicide can trigger clusters. Older adults, the sources warn they often downplay their mental state and complain about physical, somatic symptoms like insomnia instead. For LGBTQ+ youth, environment is everything. They face a 20% higher risk of attempting suicide if they live in unsupportive, discriminatory places. And for military folks, the risk is heavily tied to interpersonal trauma. And looping back to those devastating Indigenous statistics we saw earlier, the research points to an incredibly powerful protective concept called cultural continuity. This is when a community actively maintains or reclaims ownership over its traditions, its language, and self-governance. The data is amazing here. First Nations communities with high cultural continuity have drastically lower suicide rates. It is quite literally one of the most effective, proven buffers against the deep wounds of intergenerational trauma. Finally, section 6, meaningful interventions and safety. Okay, let's turn all this theory into concrete action. When you're treating someone who engages in non-suicidal self-injury, just telling them to stop literally never works. Instead, clinicians use a structured 6-step recovery approach. You start by setting limits for immediate physical safety, sure, but you quickly move into figuring out the motive behind the injury. Remember, it's a coping tool. The goal is to help them learn self-control and swap out the physical self-harm for healthier, sustainable coping skills before they enter a long-term maintenance phase. Now, what about the immediate physical environment in a clinical setting? We use something called milieu management. Basically, we are scrutinizing everything. That means meticulously removing any environmental hazards, sharp objects, anchor points on walls, you name it. It involves continuous observation during risky times, like shift changes. But it's also about looking ahead, setting up solid aftercare referrals, reconnecting the patient with their support network, and super careful medication management as they transition back into their real life. So I want to leave you with this final thought. A real risk assessment isn't just some defensive checklist to keep a person breathing for 24 more hours. If we stop trying to sterilely predict suicide and instead use the tools, the data, and the communication strategies we've talked about today to truly, genuinely listen, we can actually help people navigate their way out of the dark. We can help them find their reason for tomorrow. The guidelines are all right there. The real question is, are you ready to listen?